decades now, keeping doctors from being sued for frivolous reasons, helping practitioners avoid assaults on reputation, and all other sorts of paper cuts that make practicing somewhat more difficult than it has to be. All right, so the topic du jour is anatomy of a medical malpractice lawsuit. Let's get rolling. Most of the time, doctors get introduced to the medical legal world is when they are sued. When they are sued. Do we learn anything when we're medical students, residents, or fellows? Nope. I know that I certainly didn't. First time that I learned anything about medical malpractice litigation was when I was sued. And I must admit, it came as a surprise, indeed a shock. Very few places to turn. And I don't think that I was unusual. I think that most people who are in the real world of practice are entirely unprepared for their first lawsuit. All right, so let's take a little bit of a look into what the medical legal system is designed to do. There are several big domains in the legal world, one of which is contracts, the other one is criminal law, and another big bucket is tort. Tort is designed to keep negligent events from happening. Well, it's designed to do a number of different things, but negligence is one of them. And since negligence is such a big component of this, we're going to focus on negligence. And one of the main goals of the tort medical legal system is to prevent negligent events from happening. Why? They know the system knows that people hate lawsuits. They hate being sued. They probably hate lawyers too. They love their lawyer, but they hate lawyers in general. And the underlying principle is that if the threat of litigation is significant, people will do whatever it takes to prevent the negligent action. Number two, the other goal of the medical legal tort system is to make injured parties whole. That is to put them back where they were before they were negligently injured. But this is a legal fiction. You can't put people back where they were before. If they become blind or lose an arm, they don't suddenly regain sight. They don't suddenly grow an arm. So it's a legal fiction. In America, we make things right with money. Dollars go from point A to point B. In a well-functioning system, the tort system would keep patients safe, and those who are negligently injured would be timely and appropriately compensated with a predictable sum. I speak as a physician. I also speak as an attorney. I'm not sure that the medical legal system does either. I'm not sure that it actually deters negligent events. I'm not sure that it actually makes injured parties whole in a consistent way. But I will tell you that it does impact behavior with the advent of defensive medicine, if nothing else. So how frequently are physicians sued? And it's actually higher than you would think. Of course, it depends upon where you live. It also depends upon the type of specialty you practice. But for a high-risk surgeon, it's about 20% a year. I want you to pause to digest that. So for a high-risk surgeon, it's about 20% a year. Now, the good news is most of the time doctors win, meaning that the suit is dismissed or the physician prevails in a court action, meaning the carrier pays out a claim at under 5% a year. So you've got 20% being sued per year, but only 5% pay out. Those are good odds, but to the extent you have to defend yourself in an action, it's very time consuming, very stress provoking, and you don't know what the outcome will be. And put differently, if you just look in the aggregate, how frequently you'll be sued over a career, think of it in this way. The odds of going your entire career will stay up to age 60, although many people practice beyond age 60. The odds of you having never been sued one time in a high-risk specialty, such as mine, neurosurgery, is about 1%. 1%. So the likelihood of you being sued in a high-risk specialty over your career is near certainty. It's going to be 99%. So if you are sued, just remember lots of other people like you have been in your shoes. Many people who have been sued are like you. They never thought they would ever get sued. They did get sued. You don't hear about it, but for the most part, if you query your colleagues, you'll find that they're high risk in a high risk specialty in a high risk area. It's not if you will be sued, it's a question of when you'll be sued. All right, this is an interesting study. It's a little dated now. It's over 10 years old, but it was put out in the New England Journal of Medicine. And what you can see is the annual incidence of claims based on specialty. So my specialty is on the top, neurosurgery. Any claim is just shy of 20% per year. That's 20% per year. And the payout here is less than 5% a year. So it dovetails with the conclusion I referenced earlier, which is, for the most part, you're likely to be sued in a given year, but the payout it's unlikely to be associated with a payout. Most of the time, the suit will either be dismissed or you will prevail, but you'll still have to defend against it. It will be time consuming. It will be stressful. If you just look at all physicians right in the middle, that's in between anesthesiology and emergency medicine, you see the numbers on the order of about 7% a year, again, with payout being about 3 to 4%. And psychiatry down at the bottom seems to have the most favorable um, frequency as it relates to professional liability. The numbers are quite low. Pediatrics also quite low. So what is the take-home message from this? If you practice in a specialty, procedure-oriented, where you don't have long-term relationships with your patients, such as neurosurgery or cardiothoracic surgery, general surgery, you don't develop these long-term relationships, which can buffer you against litigation. But for those where you do have long-term relationships, i.e. psychiatry, pediatrics, family practice, even dermatology, the likelihood of you being sued goes down significantly. So one of the take-home messages is that if you can learn a little bit more about your patients, try not to be the indifferent individual that is just a technician, but actually cares about the patient, as a human being. And you'll find that that actually goes a long way to mitigating the likelihood of you being sued in the first place. All right, this is part of that same paper, which identifies the aggregate risk over time. And as you can see, the more you practice, the more likely you are to accumulate the risk of being sued. Certainly, if you're in a high-risk specialty, the number goes, as you get up to age 60 and 70, it goes up to near certainty. Even in the low-risk specialties, the aggregate risk goes up to about 75%. In terms of a payment, the payment is still quite high for high risk over time. If you look at over age 60 to 70 for high risk specialty, like a neurosurgeon or a cardiothoracic surgeon, the number is about three out of four. For low risk specialty, i.e. psychiatry, family practice, pediatrics, the risk of a payout over time in aggregate over the career, not particularly high, but it's not zero. It's anywhere between 10 and 20%. All right, so let's talk about what makes up a medical malpractice claim. So the first thing you should learn is that you don't have the burden of proof to defend. It's not like you're guilty until proven innocent. Now, you believe that will be the case. That is probably your perception, but the burden of proof is actually on the patient. The patient is now called a plaintiff. It is their burden to prove each of the elements, and there are 4 elements, and they must prove each by a preponderance of the evidence. So what is preponderance of the evidence? Preponderance of the evidence means more likely than not. So if you want to give that number, I'll call it 51%. It's a little bit more than a coin flip. If you want to look at a different type of proof, it would be in the criminal justice system, where the state or the federal government must prove its case beyond a reasonable doubt. So in my mind, that's probably 99%. And in between, there's a standard, not relevant here, but I'll just mention it for the sake of completeness, which is clear and convincing evidence, where a patient, for example, would have to prove a particular claim by clear and convincing evidence. And using numbers, that's probably about 75%. And there are some situations where a patient is obligated, now a plaintiff, to prove their case by clear and convincing evidence, particularly if they're alleging fraud. If they're alleging that somehow you spoiled the record, that you crossed things out, then you didn't have an audit trail, and you changed your observations from something that was previously damning to something that makes you look like a saint, they would have to prove that by clear and convincing evidence, which is 75%. All right, back to the 4 things that the plaintiff must prove. First, that there existed a doctor-patient relationship, and because of that relationship, you owe the patient a duty. That's number 1. Number 2 is that you breached the standard of care. You had a duty to comport with the standard of care, but you breached the standard of care. Number 3, that breach caused. Number 4, damages. The patient must be injured. Can't just be that they didn't like the way you treated them, meaning that you were mean to them, or that you had poor bedside manner, or that you didn't have adequate parking in the garage. There need to be calculable damages. So again, 4 things. There needs to be a doctor-patient relationship where you owe the patient a duty. You breach the standard of care inherent in that duty, and that breach caused damages. Okay, let's dive in a little bit more. Okay, first and foremost, was there a doctor-patient relationship? Now, typically the answer is going to be, well, yes, there was a doctor-patient relationship. This is really not that challenging for many cases going forward. I mean, if you see a patient, if you examine a patient, if you make a diagnosis, you take a patient in the operating room, there naturally is a doctor-patient relationship. And I generally tell physicians, if the patient reasonably believes the doctor-patient relationship has been formed, it really has been formed for the most part. It will be your burden to disprove it. But for the moment, if a patient truly believes, reasonably believes that a doctor-patient relationship has been formed, this prong has been met. Yes, there was a doctor-patient relationship. Now, sometimes it's not entirely obvious if there's a doctor-patient relationship. Let's talk about one situation that can come up, the proverbial curbside consult. So here's an example. You're a neurosurgeon, an internist colleague sees you in the hall, grabs you and says, hey, look, I've got this patient of mine who tripped, fell, he's in the emergency room. I'm not sure if he needs a C-spine image. Yeah, maybe, maybe not. And you retort back, an imaging study is entirely unnecessary. And then your internist colleague goes back and documents your opinion in the chart. Okay. They document your opinion and they say, hey, look, I spoke with Dr. Segal. He said that in this particular case, based on the facts that I gave him, an imaging study is entirely unnecessary. So now, if your name is in the chart and your opinion is wrong, and the patient ultimately has a cervical spine injury and let's say a quadriplegic or quadriplegic, you could be sued. And here, what's crazy is that you never saw the patient, but your opinion, how it was delivered, and the way it kind of moved forward ultimately impacted the trajectory of care. There was a bad outcome. Now, at some point down the road, we'll be putting together a video on curbside consults because sometimes curbside consults are not problematic. And for the most part, you will be either immune or unlikely to be sued, even if your name appears in the chart. But more on that later. All right. The second prong is the standard of care. Did you breach a standard of care? And most of the time, the standard of care for both the plaintiff and you're now labeled the defendant, is demonstrated by expert witnesses. So each side will hire their own expert to explain how you either violated a standard of care or how you adhered to the standard of care. The standard of care is what a reasonably prudent doctor in your specialty would have done under same or similar circumstances. Again, what a reasonably prudent doctor in your specialty would have done under same or similar circumstances. And the answer is it depends. Not every doctor does the exact same thing. So it shouldn't be shocking that experts sometimes have divergent opinions. The standard of care is not typically in some book where you can look it up. It's going to depend upon the individual facts of the case, which is why there is the proverbial battle of the experts. Part of the problem is that medicine is not an exact science. It's an art, and it's also changing. What was the standard of care today may not be the standard of care next year. But experts are brought in. Their goal is to present the case to a jury, and they buttress their reputation by demonstrating prowess in their education, training, and experience. They can also point to definitive guidelines, to textbooks, to papers. And as you know, many of the papers conflict with each other. In fact, guidelines conflict with each other. That's why there are so many guidelines out there, because there are no definitive guidelines. They are just there to guide, not there to serve as a definitive standard of care. And part of this is why the practice of medicine is messy. It's not easy. When a patient shows up to see you, there's a differential diagnosis. There's more than one way to skin the cat here. There may be more than one way to treat a patient. And with different doctors who are out there, you will find different diagnoses and different treatments. And that manifests itself in the standard of care. All right. What's really important to learn and to know is that the standard of care is not ideal care. It's not perfect care. It's not optimal care. It's a floor. You don't want to go below the floor. It's not the aspirational ceiling, but it is the floor. And if you go below the floor, you have breached the standard of care. So is there a more formal way of defining what the standard of care is? Well, it's what a majority of your colleagues would do. Some will also add, it's what a respectable minority of your colleagues would do. So I don't want to get into the weeds. Some states, most states are what a majority of your colleagues would do. Other states include the respectable minority possibility. But for the most part, if you're in this bucket, what a majority or respectable minority of your colleagues would do under same or similar circumstances, you probably have comported with a standard of care. Now, conversely, if nobody would do what you're doing, you're either in breach of the standard of care or you're conducting research. Okay, if you're the only person doing something, you could certainly argue, hey, I was doing research. And research isn't the standard of care. Research may become the standard of care down the road. So, for example, if Pfizer is doing a drug trial, it will hire a collection of clinicians to test its compounds on a cohort of patients. And is that the standard of care? No, it's not the standard of care because they're testing it out to see whether this compound may be useful for treating a particular condition down the road. So there is a place for research, but research is not what is typically addressed in the conventional medical legal tort system. Can you be sued doing research? Yes, this is America. You can be sued for virtually anything. And if you want to do research, you want to make sure that you've got coverage for any challenges related to research. But that's another story for another day, maybe another video for another day. We'll see. All right, the third prong is that your breach in the standard of care on your patient must have caused an injury, must have caused an injury. So here the plaintiff must show that the violation caused a discernible injury. Okay, so let's go through a particular example here where the patient has an injury, but a breach in the standard of care did not cause that injury. So in this vignette, your patient is recovering from a spinal operation, and while he's recovering, he dies from an incidental asymptomatic cerebral aneurysm. Nobody knew about it. This had never been diagnosed previously. He had no symptoms pointing to an aneurysm, but it blew while he was in the recovery ward and recovery unit. And he clearly has damages because he went in for spinal surgery and now he's dead. But there's nothing you did that caused these damages. It was an incidental finding related to an asymptomatic aneurysm that caused the problem. You may have some explaining to do. My guess is this is not just going to go away, but in terms of being able to prosecute this case from beginning to end and have the patient, now the plaintiff or their family, collect a judgment, I think the odds of that happening are pretty low. All right, so let's talk about you breached the standard of care, but nothing happened. You dodged the bullet. So in this vignette, let's assume the standard of care would be to give prophylactic antibiotics for craniotomy. And for whatever reason, you forget. You just do not deliver the antibiotics. If the patient never has any sequela from that, the patient never gets an infection, there are no damages. It doesn't matter that you forgot to give the antibiotics because the patient has experienced no damages. You did breach the standard of care because, as we said, the standard of care is prophylactic antibiotics for craniotomy, but it doesn't matter. There are no damages. Now, does that mean you'll never have any problem associated with that? No, because you did breach the standard of care. It's possible a peer review committee may take issue with you and bring you before the committee. It's possible the Board of Medicine could learn about this, and the Board of Medicine doesn't necessarily need to see damages. They would just care whether there's been a breach in the standard of care. And if so, the answer is yeah, they can take action. But for the most part, since we're limiting our discussion to litigation, if there's no injury, there's no lawsuit. And for the most part, most attorneys get it. If they're not looking at a big pile of gold at the end of the rainbow, then they're not going to be interested in prosecuting a case. And even if they were interested in prosecuting such a case, it likely would go nowhere. Okay, so getting back to our 4 points, let's go through that one more time. For a plaintiff to prevail, they need to demonstrate by a preponderance of evidence, that's 51 to 49, several things. One, that there was an established doctor-patient relationship, and because of that relationship, you, the doctor, owed this individual a duty of reasonable care. Number two, you breached the standard of care, what a reasonably prudent doctor in your specialty would have done under same or similar circumstances. Number three, that breach, number four, caused damages. All right. So now that we've chatted about the mechanics of litigation, are there things you can actually do to keep yourself out of the crosshairs? Are there things you can do to prevent being sued? And the answer is yes. There are a number of things. So first and foremost, be nice to your patients. Treat the patient as you and your family want to be treated, especially if there's a complication. And I think it's just a truism that patients and their families are less likely to sue those individuals they like. So if you're an ass, if you're a jerk, just makes it easier for them to sue you. If you're pleasant, kind, and reasonable, they are less likely to sue you. It doesn't mean that that's going to keep you out of the hot seat in all circumstances, but it just means it's less likely. This is a numbers game. Number two, and I can't repeat this too many times, be a good communicator. Frequently, lawsuits are not about the cash. I know we believe it's about the money, that the patient, now the plaintiff, is a money grubber, but most lawsuits are actually not about the cash. They're looking for answers. And a lawsuit is typically the end result of a frustrated search to get answers. They've been unsuccessful. So if the family wants answers, be candid. Give them answers sooner rather than later, because the more they have to work to get answers, the more they will come to conclude you have something to hide. And because you have something to hide, you did something wrong. And the truth is, if you did everything right, if you were reasonable, even if the patient experienced a horrific complication, the sooner you deliver competent, timely answers, the less likely you are to be sued. Not a definitive, you will never be sued, but you're less likely to be sued. If, as a doctor, You tend to get better over time. So I'm going to just come out with a statement: avoid overly aggressive treatment, give patients options, make sure they understand the risk and benefits of each option. I can't state this enough. Informed consent is not a document that a patient signs on the way to the operating room. It's a process. And to the extent the patient understands the true risk of the procedure, first, what are the common risks? And then what are the unlikely but horrific uh, potential complications? The more likely they will become a partner in this process. But if you just shove a document in their face while they've got propofol getting ready to go into their veins, it's hard to conclude that they were given true informed consent. So I think there are ways to do this properly. I had one mentor, he was wonderful. He said, you spend your entire residency learning how to operate. You spend the rest of your career learning how not to operate or who not to operate on. Not every patient needs a procedure. Sometimes it's not a great fit. And one of the things you can do, instead of having to spend 25 minutes going over the detailed but similar risk, benefits, and options over and over again, which can be mind numbing, is to craft a video, which for your common procedures explains the common risk, benefits, and options. Have every patient see it from beginning to end. You will save yourself 20 minutes on each of those patients. We'll be doing it properly. And then the patient can come in and you can have a much more narrow, tailored discussion relevant for that individual patient. The other thing is by having these videos posted online, for example, it could serve as a marketing tool. So it's not just, hey, this is risk management 101. It's also marketing 101, two ways to skin a cat. All right, be careful about who you take care of, particularly in elective practices. It's often said that the customer is always right, but my corollary to that is not everyone has to be your customer. Not everyone has to be your patient. And sometimes it's just better to say no, particularly if you believe there are some challenges with the individual up front. You're not going to manage their expectations. Um, I think you can send them elsewhere. And this is particularly the case if you do not have the skill set to do a particular procedure. If you don't have the skill set, send these people to other practices that have background training and experience. If they're not a good fit, don't do the procedure, because if you do cause a complication, you and this patient are going to be seeing each other a lot going forward. So if you have the willies about potentially even seeing the patient for one post-operative visit, remember that if they get a horrific wound infection, you'll be seeing them for more than a single post-operative visit. You'll be seeing them over and over again, and you may actually see them in a courtroom. All right, this is one of my favorite books. What can you avoid? What can be done to avoid being sued? There's a book called Sorry Works by Doug Wachesnik. His name is spelled exactly like it sounds, Doug Wachesnik. And so who is Doug? He had an individual, had a family member, brother, who passed away because of an institution's medical error. And Doug and his family started searching for answers. And what he got was deny and defend. He didn't get any answers. He got, hey, we did nothing wrong. They denied there was a problem, and they said, we'll defend to the end of the earth. What's interesting is that the family wasn't even looking for cash. All they wanted was an apology. But this book is a how-to manual on how to express sympathy to one of your patients who experienced a complication. I mean, it really is brilliant. You can purchase it on Amazon for a few bucks. I say buy it, read it again, read it once a year. It really is hands down one of the best books I've ever seen or read on what can be done to avoid being sued, in particular, how to manage a complication. Are there others out there? Yes, there are others out there, but this is one of the best. Don't make angry patients angrier. If the patient's angry, they are certainly more likely to sue, but sometimes you can add fuel to the fire. Let me give you an example. If you've collected thousands of dollars from an insurance company, but the patient hasn't made their payment for $22, I'm not sure I would send that patient to collection. In fact, I'm positive I would not send that patient to collections because there's a reason they're not paying you the $22. They are pissed at you. And if you send them to collections, potentially destroy their credit over $22, the angry patient will become even angrier. An angry patient sue, they file complaints to the Board of Medicine, they beat you up on the internet, all sorts of nastiness. So the corollary to this is that if you think somebody's angry at you, but you have these mass marketing campaigns, remove that patient from your mass marketing list. So if you've got an email list or a text messaging list that just sends out messages to all of your patients talking about this great new procedure you do, your wonderful hours, your great service, the terrific testimonials, you probably don't want to be advertising or marketing to that angry patient. As soon as you know they're angry, pull them out of your marketing program, because what you'll be doing by sending this angry patient a marketing message is taking salt and rubbing it right into their wound. You don't need to do it. You probably don't want to see them again anyway, so no reason to market to someone you don't want to see going forward. All right. If a person is beating you up on the internet, social media, or a physician review site, do what you can to de-escalate. I know this sounds crazy and old school, but try calling them, particularly if you're not aware that there was a tremendous problem in the first place. Try calling them. The bar is so low, they don't expect that you'll ever call them. So if you do call them, you're already ahead of the 8 ball here, which means that you may have started the process of de-escalating. I would then listen to see what is making them angry. You don't have to get into a debate. The goal here is just to find out what's causing their angst. And to the extent you can solve the problem, go ahead and solve the problem. So there are many ways to learn early if there's a problem before it turns into litigation. Frequently, an ugly review on the internet or on social media is the canary in the coal mine. This is the early stage of an escalating conflict, which can end with somebody going to a lawyer. All right, so I practice what I preach. I was a neurosurgeon for a decade. I was once sued for what I perceived to be a frivolous reason. The single expert who testified against me had actually been expelled by my professional society, the American Association of Neurological Surgeons, precisely for delivering frivolous testimony. Yet there he was on the circuit testifying against me. The procedure was something he'd never performed in the past. So I was dropped about 2 weeks before trial. So that's good news, but I never felt as if I won anything. I just lost less. So what did I do? I started an organization called Medical Justice, focused on keeping doctors from being sued for frivolous reasons. We do a bit more than just keeping doctors from being sued for frivolous reasons, deal with all types of escalating conflicts, and now have institutional memory, having worked on over 5,000 cases. So our goal is prevention. To the extent we can nip something in the bud, great. But if you are sued, we have a collection of strategies on how to put the toothpaste back in the tube, how to potentially de-escalate the conflict, or mitigate the damages. If a check's going to be written, is there a way to make that check smaller? Is there a way to prevent having you reported to the data bank? The answer is maybe, to some or all of those. You can't really go through an entire lifetime, an entire career without ever having a complication. And of course, a complication can spark a lawsuit, but decreasing the likelihood of a lawsuit is not always challenging. If you are sued, don't jump off a ledge. Just view it as a frame in a long movie. It's not the entire movie. It's just a snapshot. This is not your entire career. You don't want to be defined by, the worst 5 minutes of your life. And I can guarantee you that your colleagues, your peers have all been there before. All right, so let's wrap up. If you're a doctor, odds are high you will be sued at least once in your career. Fortunately, with most lawsuits, they are dismissed where the physician wins. The patient, now the plaintiff, must prove by preponderance of the evidence several things: that there was a doctor-patient relationship, that there was a breach of the standard of care, that breach caused damages. And much of that is proved by an expert. Certainly, the standard of care as well as causation are proved by experts. And there are ways to mitigate the likelihood of being sued. Be an effective communicator, be nice, and you don't have to take care of every patient. Take care of most patients, but you don't have to say yes to everyone. And with that, I bid adieu. Thank you so much for your attention.